Good day, and welcome to Building a Star Asthma Care Team, Best Practices from the 2006 Asthma Award winners. This is a web-based presentation sponsored by the United States Environmental Protection Agency, and we're glad you could all be with us today. Next slide. I'm Tracy Mitchell, and I work at the Environmental Protection Agency in Washington, D.C., and I'll be your facilitator this afternoon. I'm very excited to congratulate and welcome our 2016 Asthma Award winners as they share their successful program strategies with us. Before we get started, I'm going to give a quick overview of the webinar, walk you through some housekeeping items, and provide some introductory remarks. Then we'll turn it over to our featured speakers. Before we dive into the presentations, I'd like to get a sense for who's with us on the phone today. Great. So it looks like about a third of you are healthcare providers. We've got about a quarter of health plans and about a quarter of government agencies and about 10% of community-based organizations. So it looks like we have a great audience today with a wide variety of disciplines and organizations represented. So that's very exciting. Secondly, we'd like to know, what are your main challenges in facilitating communication across your care teams? Okay, so it looks like about 50% of you have difficulty connecting with various care providers to discuss patient access. Very interesting. About 15% said communication channels are unclear, and about another 15% said delays in sharing important information. So I think you're in for some great information today. Our speakers will have great insights on how you can tackle one or more of these challenges. So I'm very excited to get started. So our plan for today is to give you a brief background on the National Environmental Leadership Award in Asthma Management and discuss the framework that many of our award winners have used. This is EPA's system for developing high-quality asthma care, and this will just give you kind of some perspective as to where these programs are coming from. Then we'll turn it over to the award winners so that they can share the results that they've received through their programs and why they are award winners. Okay, so let's just talk a little bit about the National Environmental Leadership in Asthma Management. This is the highest recognition in the country that a program and its leaders can receive for delivering excellent environmental asthma management as part of comprehensive asthma care. What winners receive is a place in the Hall of Fame on asthmacommunitynetwork.org. This is where we highlight and spotlight each of our award winners. We provide national recognition through press releases, blogs, and other social media. There's an actual Crystal Award, and then the opportunity to serve as mentors in other programs across the country, to two other programs across the country to achieve impactful results. On the next slide, you can see some of the logos from previous winners. Since 2005, EPA has recognized 38 health plans, healthcare providers, and communities in action for their best practice approaches to delivering, again, comprehensive asthma care, particularly the environmental management part of it. Many of these award winners have used receiving this recognition as a way to help market, expand, and sustain their programs. And all of the profiles of our previous winners and their program descriptions are located on the Hall of Fame at asthmacommunitynetwork.org. So again, that's the place to go to learn more about these programs. Next slide. As I mentioned earlier, many of our award winners have used EPA's system for delivering high-quality asthma care, which features essential components necessary to develop an effective and sustainable asthma program. You can see in this diagram, the system is a conceptual framework based on the results of the Asthma Health Outcomes Project conducted several years ago by the University of Michigan. This system identifies the core elements of successful asthma programs and the processes that drive their implementation, continuous improvement, and sustainability. The key 5 drivers in the system are in those circles in the middle, and as you can see, they're committed leaders and champions, strong community ties, integrated healthcare services, tailored environmental interventions, and high-performing collaborations. The system is flexible, and any program, regardless of its size, of its budget, of its target community, can use the system to guide its work. So let's talk a little bit more in detail about a couple of the key drivers. It's important to build a strong foundation in order to achieve successful outcomes. I think we all know that. Community health workers and health educators and other staff are core components of asthma programs. They deliver crucial asthma care directly to patients, such as in-home visits, that identify asthma triggers where people live, and it provides education for managing asthma for patients and families in a familiar environment. Integrating healthcare services along with a well-trained staff helps asthma programs provide more effective care. And so some examples of integrated services include things like providing patient referrals for in-home services and using electronic health records or registries to facilitate sharing of patient information with different care providers. And that was one of the challenges we heard from you. So I'm excited that we have information to help you. Today you'll hear from our speakers about the strategies they implemented for training their staff to provide optimal asthma care and how they integrated asthma care services throughout their program teams. On our next slide, we realize it's hard to do this alone. Asthma care takes partnering with organizations, and it's key to partner to provide a high level of asthma care. Many of our speakers, as you'll hear, have connected with other organizations in their communities to access additional services in order to deliver comprehensive services. Building partnerships with organizations that are active in your target community and seeking out organizations that provide complementary services helps to foster strong collaborations. Collaborating also builds credibility. Collaborate with established organizations to build the social capital and local infrastructure essential to your program's success. Each of our programs today will describe how they reached out to other organizations in their community to collaborate in order to target underserved populations. And you'll hear some innovative and creative solutions demonstrating the value of thinking outside the box and building community support and buy-in. And if you're interested in getting more information about the system, again, you want to go to asthmacommunitynetwork.org for more information. On this next slide, we realize another component of delivering care is sustainability, and something that every program must consider. As organizations seek to increase their program's impact, pursuing sustainable financing options is imperative. Using data to demonstrate your program's value is essential. Present data that matters to potential funders and payers and that demonstrates the need for your program and your impact or your value proposition and the impact that your program is having on asthma outcomes. Also, it's important to make it easy to support your program. Identify discrete program elements and their costs so that funders and payers can support individual elements if they're not ready to support the program as a whole in its entirety. Establishing a strong workforce through community health workers and other asthma care providers is a building block, as you can see, for programs seeking sustainable financing options. A strong workforce partnered with a program that includes in-home asthma visits creates a solid foundation. Each of our speakers today will share how they were able to successfully build a star asthma care team and how this contributes to program sustainability. Next slide. Finally, to help you make sense of the latest healthcare policy changes and new opportunities for financing evidence-based in-home asthma services, I want to introduce you to the Financing In-Home Asthma Care microsite, again on asthmacommunitynetwork.org. This site focuses on delivering and on information on delivering and paying for in-home asthma care to improve outcomes for primarily children with asthma. You'll find a wealth of information and resources on topics such as the value of in-home visits, building your workforce, effective reimbursement strategies, understanding the options, and making a case to funders. And again, you'd want to visit asthmacommunitynetwork.org/financing for this information. So I'm ready to turn it over to our first speaker. First, I'd like to introduce Stacy Chacker from the Asthma Regional Council of New England. Take it away, Stacy.
Hi, everybody. The Asthma Regional Council, as you can see on our first slide, is a project of Health Resources in Action, and we were awarded for our New England Asthma Innovations Collaborative. And I just want to really thank the EPA for this honor. We really appreciate it. So the New England Asthma Innovations Collaborative, or NEAC as we call it, as already said, is a project of ARC. It was established in 2012. We wrote a proposal, put together a partnership, and wrote a proposal to Centers for Medicaid and Medicare Innovation, and were awarded $4.2 million. We're currently in our last year. It's a no-cost extension year, working on our final evaluation. So the goals and the partners. So I'm assuming that most people are familiar with CMMI. Is really about the triple aim, really to improve quality of care, improve health and quality of life outcomes, decrease healthcare utilization. And from our outset, we included advancing sustainable payment systems. We're based in 4 states. There was a lot of work, not in all these states, but with several of our partners already working on asthma home visiting, which I'm going to talk about our intervention in a minute. These are our partners. You can go back and look at this slide. We have 9 providers in 4 states. So they're hospitals, a federally qualified health center, just a health center, a pediatric practice. From the outset, we also engaged Medicaid payers to get claims data, as well as to have meetings with and to ask for commitments so we could demonstrate a return on investment. And we also engage workforce development partners to do training with both of our community health workers as well as our supervisors, and to provide avenues for people to become certified asthma educators. So Health Resources in Action has served as the convening organization, as an evaluator, and working in policy work. So as I said, we're a community health worker-led asthma home visit. We're actually really proud. We've done a lot of work that has been replication and learning from Seattle-King County. Hi, you guys, and thank you. So the community health workers go into the home. There's been 3 or 4 visits assessing a patient's needs in their home environment, providing the education, providing environmental supplies, and we have required HEPA vacuum cleaner as well as mattress encasements, and then there's some other optional supplies such as some very low-level IPM supplies, and then really focusing on the quality of life and experience of care. So motivational interviewing is really important, increasing asthma action plans, connecting back to the primary care so they can learn about what's going on in the home. And then, of course, referring for needed services for families such as heating assistance or WIC. And you can see our target population here. For poorly controlled asthma, we said it had to be at least 1 ER visit or hospitalization, and in some cases, a course of corticosteroids, oral corticosteroids. Over a 2.5-year period, our 9 providers provided the intervention to 1,145 kids. We collected data during the home intervention that was both self-reported from the caregiver as well as observational data from the community health workers made. We saw improvements. This is the high-level stuff. If you have more questions, I'm happy to answer it later. But to the home environment, such as decreases in mold, decreases in the amount of environmental tobacco smoke exposure in the home, improvements of quality of life, kids going to school more, and parents going to work, as well as an increase in asthma control. And we saw decreases, self-reported decreases in ER visits and number and length of hospital stays. We're also conducting an economic evaluation that is based on claims data. So we're getting all claims data from, actually it's turning out to be from 6 payers, for all the kids in their intervention, and we're developing a comparison population from the claims data. This first preliminary analysis was based only on 51 patients. Those are the only ones we could get data for in the first round for 6 months pre-post. We are actually now in the process of getting our final data from across the 6 states. We anticipate that we will have data, probably a complete data set from at least 600 to 800, maybe more, of the participants. So from the preliminary data, you can see that we've had significantly statistic findings that had showed total health care costs decreasing and improvements in terms of asthma-related use. But we are really looking forward to seeing our final cost analysis. Obviously will be for a much more significant number as well as time period. So as I said from the outset, one of our major goals is pursuing sustainability. So unfortunately, some of our sites, out of 7 of our sites, only 4 were able to continue. We have not gotten to the point of sustainability yet. We've gotten to interim sustainability. Some sites are continuing with community benefits. 2 sites have some funding from the Department of Public Health and some donor funding. But as I said, we are continuing efforts. Once our final economic analysis is done, we'll be having individual state meetings with payers and ACOs. We have had New England region meetings before, but we have determined with our partners it's really important that we drill down to everything's really different in each state. Some of our providers are building off the work that we've been doing, seeking funding from NIH or from HUD. In Vermont, they're working on code changes for certified asthma educators to be able to go in the home. Really exciting, there's negotiations that are currently going underway with a few Medicaid managed care organizations as well as one state Medicaid office to pay for pilots for higher utilizers. There's one that's getting quite close. We're very excited about that. The CDC 618 initiative, it's 6 chronic conditions with 18 evidence-based approaches, and asthma home visiting is one of the evidence-based approaches for asthma. In New England, 2 of our states are participating in this. One of them, Rhode Island, has selected asthma. And this is really helping to propel forward sustainability in Rhode Island, so there's been a lot of focused work around that. And finally, one of our sites is participating in a feasibility study for asthma home visiting center. So we continue to work on this, and obviously with our final findings, we'll have much more to propel us forward. Our takeaways from what we've learned over the last 3, almost 4 years, is engaging payers is really critical. It takes a lot of persistence. There's a lot of turnover in payer organizations. There's a lot of changes in terms of priorities when new people come on. When I say it's medical directors, it's privacy officers. We got claims data. It takes a lot of persistence. There's a lot of details involved in that. We're actually writing a white paper about engaging payers. Engaging providers is key. We have obviously our champions who are involved, but we also know that as there's a switch to value-based payments, that there'll be opportunities to get uptake in asthma home visiting in other places. And so we are actually now starting to focus on that arena, particularly with ACOs. Financing uptake takes time. It's a long process. It's I think that our providers have really recognized that it's a marathon. Home visiting models need flexibility when you're not part of a study, recognizing that there might be 1 visit needed for some kids and perhaps there might be 8 visits needed for another family, really depending on the risk that's involved. And learning communities help support replication. We've seen some replication already in New England, and we're looking forward to seeing further replication. And actually, while I'm on learning communities, that we also know that community health workers, part of our project was that we had a quarterly continuing education meeting for community health workers. Whenever you can build in any kind of continuing education and networking for community health workers, I would say that's really important. It's just our contact information from our team here at Health Resources in Action. And again, I just want to really thank the EPA for this recognition. Thank you.
Great. Thank you, Stacy. What a variety of partners and a variety of funding sources that you mentioned, and a great example of state-specific needs and activities. I think we look forward to hearing about the white paper you're developing and getting more information from you about that. So thank you again. Next, our next speaker represents our healthcare provider winner, Urban Health Plan. I'd like to welcome Dr. Samuel DeLeon, the Chief Medical Officer at Urban Health Plan, and the speaker is yours.
Okay, thank you, and good afternoon. I want to thank the EPA on behalf of Urban Health Plan for the award. Urban Health Plan is not an insurance company. It's a federally qualified health center that was founded in 1974 by a pediatrician turned eventually to a family practitioner. We're predominantly located in the South Bronx, but we have clinics in Corona, Queens. Currently, we serve about 73,000 users, and last year I think we did over 350,000 visits. And when I started here 20 years ago, we had 100 employees. Now we're past 800. So the way we started Asthma was with the Bureau of Primary Health Care, which is a department of HRSA that funds federally qualified health centers. And so our asthma venture started with participating with the Bureau of Primary Health Care's asthma improvement program. And they taught us to use a model that's similar to what the EPA presented. We use the CARE model, the model for improvement, and the learning model. And those things, that methodology of improving our treatment of patients with asthma focused on all these things that you see here. So, medical assistants were involved. The providers needed to be taught on how to properly document the ICD-9 codes and talk the same language. We use health educators and so forth. So our team really consisted of providers, but we needed health educators. We needed the medical assistants because they interacted a lot with the patients. We focused a lot on the social determinants of what patients had because medication we could give them. So an integrated pest management program is one thing that you had to do because once the patients left our clinic, then we had to focus in the home and we needed partners to help us do these things. As the EPA said, you can't do these things by yourself, so we've had a lot of collaborative partners, the EPA one of them, and then now as things have evolved and New York State and the country is restructuring the way healthcare is delivered, in New York State, we're focusing a lot on delivery system reform incentive payments, which is a program that's run by the state of New York. When we started in 2001, we started with 125 asthma patients we focused on. We had many, but we focused. Now, we went through all this evolution using the CARE model, the model of improvement, and the learning model, and this is what we currently have. So each year, we see close to 13,000 individual users with asthma. And they may generate many more visits, but at least they come once, and that's our registry. And symptom-free days, the use of anti-inflammatories, severity assessment, and that's talking the same language so that people understand what patients are. We focus on decreasing ER visits and things of that nature. And naturally, we want to focus on kids so they don't miss school. And at one point, we participated in a little study with the New York City Department of Health and 4 other health centers to see whose program had the best return on investment, so to speak. And the results were really astounding. Ours was a program that reduced in adults costs by 22%, and in children by 39% relative to everybody else. As they said, we needed to sustain the program. So the way you sustain the program, I at times people would ask me, so you're putting all this effort in place, how do you sustain it? I couldn't answer that question until it hit us that we started to increase our caseload, so we saw more patients. And now as healthcare is changing from a fee-for-service to a value-based system, I think we've set, at least in asthma and in other disease entities, a structure where we will be able to live in a value-based payment system. And that's how we'll maintain sustainability. We'll keep people out of the ER, out of the being hospitalized, and minimize cost to the system. So in general, I just want to say that we've tried to maintain a program where we assign ownership to people, we meet regularly, we involve a lot of people. This is just not about a physician. We continuously train staff whether they're new providers. We give feedback to everybody, the CEO, myself, all the providers. And then moving forward, what we're going to do is take what we've learned, and now we've developed our own research department, so we'll be able to focus more on other things related to asthma, but with a research eye. We're going to really do a laser focus on the social determinants of health. We're going to massage things so that we're going to use the evidence base that we have and apply the art of medicine to it, because at one point you need to do that. And of course, telemedicine and telehealth is coming, so we're going to use those tools in order to improve our program. So that's it. Thank you very much.
Excellent. Thank you so much, Dr. DeLeon. Your program is really a great example about using technology and the registry. You've sustained your program for over a decade, so it's really incredible. Your cost savings and your return on investment is a great example of what we're all trying to achieve. And I found it very inspiring that even though you've won this award, it sounds like you're still evolving your program and still working for continuous improvement. So that's very exciting, and hopefully we'll be able to have you back on another webinar to give us an update. Right now, I'd like to move along to our next presenter, the second Community in Action awardee, Public Health Seattle and King County, and representing them is Bradley Kramer, the Community Health Worker and Program Manager. Thank you, Bradley.
Hi, this is Brad Kramer. We're, of course, honored to receive this award. Joining us on the phone today is Dr. Jim Krieger, our founding medical director. He will be available for question and answers afterwards. And when I told him about this award, he noted that this really goes to dozens of community health workers and staff, hundreds of partners from many regional organizations, and thousands of clients in our service years of 20-year history of this program. We're operated out of our regional health department, we serve a large service area covering an area of about the size of Delaware and just over 2 million residents. In general, our programming has been tied to research grants. These grants have been very specific to have very specific eligibility criteria, but our focus has always been on the low-income, underserved communities. Our programs are designed and targeted to those most in need with uncontrolled asthma, and as with most regions, our high asthma prevalence maps to the social determinants of health. The core of our program is the community health worker model. And this is a model that we've helped develop over the past 20 years with our projects contributing to the evidence base and serving over 4,000 clients and homes. Our results in our model is similar to what you saw with New England, decreased symptom days, fewer ED visits and hospitalizations, improved quality of life, and overall healthcare savings. We've shown positive results across ages and communities. I'm not going to revisit the community health worker model. Is very similar to what you saw, and these protocols are documented well on our website. The secret to our success is largely with the CHWs themselves. The individuals themselves have the qualities essential to meeting the clients where they're at, and we rely heavily on motivational interviewing. Our program staffing varies over time. At the core, we have the community health worker, and we have 4 currently. Our program support diagram, you can see the community health worker as the center of our programming and support structure. And the essential elements are for our service providers are that program manager, the clinical advisors. We have both a frontline nurse and our medical director, and a training core with a heavy reliance on motivational interviewing expert that accompanies home visits, advises during weekly meetings, and provides continual professional development for the community health workers. We have additional support to keep our unit running and keep the staff engaged in the broader health department team. And we have an evaluation team for quality control and in our heavy research overlay that's required by our grant obligations. And these are all run out of our agency, the health department. So while the core of our work is in the home, pairing the CHW with our client with uncontrolled asthma, we do have several other partnerships designed to support that household and their asthma care. Our current project is focused on clinic quality improvement in the primary care setting at our community health centers, focused on routine follow-up visits for asthma care. We're also working with care managers at our Medicaid managed care organizations. And we have additional pilot work that teams up with other home resources displayed here, weatherization services, tenant legal services, bringing best practices in asthma care to pharmacists and child care. I've been asked to highlight two areas. I also focus on weatherization and then our clinic to community health worker communications through an electronic health record. Partnerships are essential to our success. This is an example of how building a partnership can, over time, potentially lead to sustainable funding. So in 2009, we had a grant from the HUD Office of Lead Hazard Control and Healthy Homes that looked at pairing weatherization services with community health worker education. Concept more common nowadays and referred to as weatherization plus health. We built this partnership with King County Housing Authority, an area provider of home weatherization services, with a client overlap meeting similar eligibility criteria. This is a good fit. We effectively worked with them on a complex research process and ended with positive results showing that asthma outcomes for those that were in both weatherization and CHW services were better outcomes than those compared to those with weatherization alone. The partnership went dormant after the funding ended, and we occasionally referred to weatherization, but to make that pathway a standard and offered to all clients, you need to reinforce it with staffing, funding, and standard protocols. Luckily, weatherization plus health is a concept that's spreading, and recently, in the past couple years, built on regional and national examples, our state legislator took this on to pass a bill to pay for weatherization plus health services through our State Department of Commerce. The first wave of pilot funding was just released. It caused 6 weatherization service providers to pair with asthma education providers across the state. Most of these are brand new relationships. Ours was a renewed partnership. During this initial pilot stage just started, again funded by the State Department of Commerce, we'll show that these relationships can build sustained pathways for a more clinical or health-based service referring directly to weatherization. If successful, the program will continue funding on an 18-month cycle. So improved cross-team collaborations is my next topic. We've built an asthma template in the next-gen platform, which is the electronic health record platform used by our clinic partners. Much of the template is designed around clinic workflow for a planned asthma visit, but the part I want to highlight here is an element of the tool that is focused on cross-team collaboration, broadening that communication from the primary care team to include external care teams, in this case, our community health workers at the health department, and then also the health plan care managers. So we first looked across stakeholders to identify a core set of variables that they wanted to share across these teams. These teams identified wanting a dialogue box, and that's what you're seeing here. And you're only seeing a small part of the template. And this captures brief communications, action items, and services delivered. Here's an example of, so you're seeing an example on the screen. We asked the community health worker to share essential pieces that they'd like to convey to the primary care team. The story was fascinating with lots of details. And then we trained them on how to distill this down to a clinically relevant message. So submitting the message then prompts the response from the primary care team. Usually the response is to follow up with the patient and make an appointment. So you'll see on the bottom left, there's also the CHW name and number are available to the clinician. It's not entered on the screen, and so the clinician, in addition to EHR communications, has access to our community health workers, and they'll join asthma clinic days and team huddles as well as consulting by phone. So there's other more traditional mechanisms as well. And so even after 20 years, like you, we struggle with sustainable funding. I'm not going to really go into this, but just you can see a few of these examples are all works in progress that we're working on. They probably look familiar to you because you're probably working on the same. And so these remain works in progress for us. And so thank you again for this opportunity.
Great. Thank you, Bradley. That was awesome, considering you couldn't see the screen and see what was going on. But we were right there with you, easy to follow, great information. Thank you so much. Really, you are another program that is a great example of program sustainability and evolving and changing over time, and your weatherization partnerships, as you said, went dormant, and now you're picking that back up. So a great example and great message for our audience. Thank you. Our last speaker is our health plan winner. I'd like to welcome Dr. Andrea Gelzer from AmeriHealth Caritas. She's the Senior Vice President and Corporate Chief Medical Officer. So welcome, Dr. Gelzer.
Thank you. Good afternoon. I'm Dr. Andrea Gelzer. And first, as the others have said, I want to say how honored AmeriHealth Caritas is to be recognized by the EPA with this Asthma Management Leadership Award. AmeriHealth Caritas is a managed care company, and we specialize in government programs in 17 states and the District of Columbia. We serve about 5.3 million low-income members through our various products. And our health plans provide Medicaid, Medicare, low-income, dual, and demonstration and long-term support services. We were founded more than 30 years ago by the Sisters of Mercy in West Philadelphia as a provider-owned Medicaid plan, and that really the impetus for starting the plan was to address a big issue that Misericordia Hospital in Philly was having with patients with chronic diseases who kept being seen in the emergency room for acute issues. They had no medical home, and so they were using the emergency room for primary care, and many of these individuals were kids with asthma. Asthma is a big concern in all of our markets, and in 3 of our markets, Philadelphia, Detroit, and New Orleans, rank among the top 10 most challenging places to live with asthma. In West and Northwest Philadelphia, and Philly's especially bad, 1 out of 4 kids has physician-diagnosed asthma or has been admitted to the hospital for wheezing. So Keystone First, our Philadelphia affiliate plan, their asthma consistently ranks in the top 10 primary diagnoses for non-urgent emergency department visits. And it's often among the top 3 conditions treated in our high-volume practices. So we've been working to provide access to asthma services and optimize health outcomes for our members with asthma for a long time. As I said, we've had an ongoing focus on asthma for years. In 2003, we developed Healthy Hoops, and it's really an edutainment program, and it combines celebrity basketball clinics with member and family-based education. So we use celebrity coaches and celebrity entertainers, and these are signature events in the Philadelphia area. And we can get 500, 800 attendees, so many of our members and their families and their friends at each of these events. And we do wellness and asthma screenings, and the kids get an asthma action plan consultation, and we demonstrate how to use inhalers and spacers and educate. And they've been a really effective hook to get kids with asthma and their families in for screenings and education. But the challenge has always been how to keep these kids and their families engaged throughout the year in the community with their providers, with their medications, with community agencies, and provide them additional ongoing support. So we've developed a very data-driven, comprehensive, population-based approach to asthma that still incorporates healthy hoops as a hook to engage our members, but it also includes a lot of ramped up, very targeted activities in the provider's office, in schools, and also in our members' homes, where we use visiting nurses and community health workers to screen and educate. And our nurse care managers coordinate access to all of these activities for the members they're assigned. And our goal is to deliver really the right set of interventions to the right members, because no single intervention works for everyone. So we've developed a portfolio of interventions, and and it's data-driven and population-based, and that's our whole program. And we work really hard to provide touch points for our members, so no wrong door, to access our asthma management activities through various portals of entry. So it could be the care manager, it could be our member services area, it could be provider offices, schools, federally qualified health centers, community agencies, churches where we do different activities in the cities, and in the home. This diagram really attempts to represent some of the complex interactions our care managers need to navigate to successfully impact a typical member with asthma. So they've got to deal with adjustments in medication and making sure, and medication reconciliations and refills, coordination of appointments, transportation assistance, education about disease management, home environmental assessments, pest and mold mitigation, like everybody said, cockroaches, even necessary home repair. All of this plus ongoing coaching, emotional support. It's often necessary between visits to the primary care provider. Quickly, I want to highlight, because I'm the cleanup hitter, I think, I want to highlight a couple targeted pieces of our program that we think are especially impactful. First, community health workers. And as most of the speakers have said, community health workers have been very effective in helping us deal with not just asthma, but other chronic disease or members with chronic diseases, and engaging those low-income members with chronic diseases in their homes. So we call them community care connectors at AmeriHealth Caritas, and they're uniquely situated really to provide eyes and ears for us in our members' homes. And these staff are generally hired from the neighborhoods that they serve, and they may or may not have any healthcare background. The skill really that they bring is the ability to empathize with the member and understand the challenges our members face, and really make a connection to the member and the family. And our community health workers also do asthma education in the member's home. And the training we use is proprietary training. So if we have a partnership in a community with a hospital or children's hospital, so for example, in Philadelphia, we have partnerships with each of the two hospitals that do a lot of the children's inpatient and specialty care. And one of our community health workers received coaching and mentorship from one of that children's hospital's asthma educators. And recently, all of our care connectors have gone through an Association of Asthma Educator education program for community health worker training. None of them are certified asthma educators. None of our RNs are certified asthma educators yet, but some have expressed interest, and so that's on the agenda. We've even embedded community health workers in some high volume peds offices in a few instances, and in those instances, they participate directly in the team huddles and the practices, and they go out to the patient's home and then they come back. And I would just give you one, as one lesson learned, the practices, or we have found, and the practices have found, that if the community health worker actually meets the member in the provider office, it's much more effective when they go out into the home, because we were sending them out into the homes first, and when we did that, in some instances, the members were really, trust is a huge issue. So it was a much more trusting and easily started relationship when the community health worker first met the member in the provider office. Another targeted strategy has been our Breathe Easy Start Today program, or our BEST program. And we developed a partnership with a pharmacy who deploys dispensing cabinets in in any physician office. The cabinets contain asthma medications and devices like spacers, and the provider enters the member's information in the computer that's attached to the cabinet, and that creates a prescription label for the medication or device being dispensed. And just doing this triggers a claim back to the health plan, and it also triggers an inventory update for future cabinet restocking by the pharmacy, and also a refill trigger for the member for the next prescription. So the pharmacy then contacts the parent 4 to 5 days prior to the refill date and delivers the refill to the member's home. This on-site dispensing allows the physician and the office nurse to provide instruction on inhaler use while the member is still in the provider's office, and ensures that the member has the medication right away. And since going live in 2014, we've deployed cabinets in 23 provider offices with more than 6,000 members with asthma participating in the program, and a 1-year pre-post analysis for practices that use the dispenser has demonstrated significant improvements in medication adherence and statistically significant reductions in inpatient and emergency room use for the providers who use it. While thousands of school-based clinics operate nationwide, few exist in Philadelphia despite a really high level of need. So we partnered with a community health center to run a clinic at 14 participating public charter schools to provide recommended asthma health screenings to pediatric members, and to also address other clinical gaps in care. Clinic has a medical assistant, administrative support, operates 5 days a week with extended evening hours as needed. It's an integrated program with support of school administration. And we reimburse all member care gap services under a flat rate. Our goal with all of these targeted efforts is really to afford the opportunity for all stakeholders to offer seamless asthma care for pediatric members in the office, at home, and while at school. And no single program meets the needs of all of our members with asthma, so we're using a multi-pronged approach, meeting the member wherever we can make a connection, partnering with providers, schools, pharmacies, local health agencies, and many community organizations. Engagement within the community is key. And I just want to say thank you, and thank you again to the EPA for our award and for this opportunity.
Great. Thank you, Dr. Gelzer. And there's so much great information that you shared. But a couple of things that struck me, we mentioned that our speakers would be talking about kind of outside the box, thinking outside the box. And I love the BEST pharmacy program you described, and the using the Healthy Hoops program, which is, like you said, wildly successful as a hook to keep members in the system. Just a great example of a health plan using high-performing collaborations and community health workers. So thank you and congratulations. And again, I'd like to just congratulate all of our award-winning programs, and thank you so much to the speakers today as representatives of these programs with their willingness to share their successful approaches so that others can learn from them. So it looks like about a third of you would like some more information on establishing collaborative partnerships. And we heard a lot of unique approaches and unique partners today, but it sounds like there's more we can learn from that. Creating a program infrastructure to prepare for funding. About a quarter of you are interested in that, and making the business case for your program. About a quarter of you are interested in that. So this is actually very helpful. And again, in the meantime, I'll just encourage you to visit asthmacommunitynetwork.org to get some information in the meantime. So that concludes today's webinar. Again, thank you. I can't thank our speakers enough for sharing their information with us. Thank you for all of you who participated across the country. We're glad you could join us and hope it was helpful. Please look on asthmacommunitynetwork.org for more information. You'll also get in your inbox, in your email inbox today, a brief feedback form that will help us evaluate today's webinar and the information of today's webinar. It will only take a couple minutes to complete, but it will be really helpful for us if you could go ahead and complete that evaluation form for us. Have a great day.